Mr Keating.
Thank you, my lady. Welcome back. We were, before luncheon, dealing with the PHE report, the terms of reference for the work you were doing investigating the apparent, to use your phrase, inequalities in relation to certain groups. And we dealt with the terms of reference and the scope of your work. The next, which was from June 2020 onwards. So the next part of our timeline really moves on to September 2020. And it's a COVID-0 meeting which you were present at, and I'm very grateful it's right in front of us there. Chaired by Michael Gove, and we see Justin Tomlinson, who's the Minister of State for Disabled People, and overleaf, top of page 2, you were there in your capacity as Minister for Equalities. If you could go to page 5, please. And in terms of context at page 5 of this document, we see that first and second paragraphs, is discussing that the first wave of the pandemic, BAME communities had seen higher case rates than their white counterparts. This was being repeated in a second wave of the COVID pandemic. There's reference to the data being perhaps skewed as a result of testing, but reference still that a BAME person, that's their terminology, was still more likely to die from coronavirus even once the socio-economic factors had been removed, with black men twice as likely to die than their white counterparts. And it talks about the increased death rate of BAME communities was linked to the fact that these ethnicities were overrepresented in 8 of the 12 most high-risk coronavirus occupations. And if we could just scroll out, please, and look at the third paragraph. So against that context, this COVID-0 report meeting then refers to disabled persons, and it says this, is that 60% of those who had died from coronavirus identified as disabled. And even once accounting for other risk factors, disabled people were 1.6 times more likely to die from coronavirus. And that spikes considerably when one considers age. And it talks about the difference in relation to gender. So Ms. Spade, now just following on from your work in terms of looking at a disproportionate impact on ethnic minority groups and disabled people, a huge group as well. Was this not an opportunity for your work to align with the work which was going on in relation to disabled persons, bearing in mind the high death rate which has just been highlighted there?
I don't think so. I mean, if I understand your question, what you're asking, correct me if I'm wrong, is that given that there were bad statistics on the disabled side as well as on the equality side, why didn't we encapsulate it altogether? There was no need to. They were doing work, certainly from my perspective, that would just have been a duplication. Simply adding it to our work stream would not have provided any additional insights. They were still part of the broader equalities directorate, and they were focusing on a particular area. And given that the work that by which time the quarterly reports that I was doing were focusing on comorbidities and multivariate analysis, it was taking into account other things like age, like sex, like geography, for instance. So that we were looking at this. We were looking at this in its entirety. Whether or not it was in a particular work stream or another, I don't think would have made much of a difference.
What would you say to the concern that the interests of disabled people was actually secondary and wasn't given a sufficient prominence at that stage in September 2020?
I would disagree with that. I think just because you're looking at things separately doesn't mean that there is a hierarchy of need. The evidence showed that disabled people were more impacted, and we were keen to ensure that it was the people who were most impacted that got the most attention. And that was roughly in order of priority, the elderly and then disabled people. This was something that was a factor. And in terms of interventions being made, those would have been considerations that DHSC would have taken into account.
But it's an obvious point, but of course disabled persons will fall within the ethnic minority groups as well.
Yes.
Let's move on to your first quarterly report, which is dated the 22nd of October 2020. And that's INQ *0. Thank you, right in front of us. So published on the 22nd of October, and you touch upon in your statement how you wrote a letter to the Prime Minister setting out the work you were doing.
Yes.
And what we're going to do is going to draw out some aspects of this. It's a significant report in terms of length. Perhaps if you could turn to page 5, please. That's the introduction there, and the third paragraph sets out the work which is ongoing. And given the stark findings in relation to ethnicity, the RDU, perhaps you could explain to everybody what that is.
It's the Race Disparity Unit.
Yes, thank you. Main focus has been to consider why this focus had such a disproportionate impact on people from ethnic minority groups, and in particular men from within groups. It talks about a separate strand of work within government is considering other disproportionately impacted groups, by that being disabled persons. The report makes 13 recommendations. If we can see those at page 6. We see the first 2 on page 6. And perhaps we could just focus on some of those, not them all, but we see there that the recommendations which you made to the Prime Minister at the time, which had been accepted in full, the first 2, and I'm going to summarise them if I may, is that NHS England must ensure that trusts implement plans for the next stage of the pandemic, and that these plans continue to reflect the latest evidence about ethnic disparities and risk factors. And recommendation 2, departments must put in place arrangements for the effective monitoring of the impacts of their policies. So October 2020, these are quite broad recommendations, would you agree, in terms of you must have plans and you must monitoring the impact of your policies?
Yes, they are broad, but I don't think we should assume that they would have been done if it hadn't been explicitly set out. But also, what these recommendations are doing are letting it be known that there is someone else marking the homework. It's very easy for people to say, oh, don't worry, we've got some plans in place. But by formalising these recommendations, they were things which we were going to be going back to check up on later. And it's almost that evidence checking process that is being validated with recommendations.
So you describe this as an evidence checking process because one would expect that these are matters which would be in place in any event, should be in place in any event. Let's turn over a leaf, please, and look at recommendation 4. Departments should continue to work at pace to develop new policy interventions to mitigate COVID-19 disparities informed by the latest evidence. You touch upon that in your statement, that this was, paraphrasing, a personal issue to you, and your view, and perhaps you could paraphrase it or say it yourself, was that you considered more needed to be done. Is that correct?
Yes, I think so.
So in relation to work to mitigate COVID-19 disparities, as of October 2020, your view was that more needs to be done and government needed to work at pace.
Yes, and I think that what's also, it may not be obvious, but what's also being emphasised there is that departments should continue to work at pace. And I think that sometimes in government there is an assumption that, well, somebody else is looking after this, so we don't need to. And it was reinforcing that principle that equalities work is done by every department, not just the equality hub. And
it may be civil service or political phraseology, but work at pace, what does that mean?
Quickly.
Yes, that's pretty much common usage. In terms of metrics and using your project management background, if we look, was there metrics to measure these recommendations? Was there something in place to make sure that, as you say, the homework was being marked?
Yes, the actual process of the quarterly reports was the metric checking, effectively. That was how we were measuring. So routinely, my team within the Race Disparities Unit would ask departments to report back, what have you done? We made these recommendations. Can you send us a list of actions that show how you are meeting this, which is all part of the homework marking,
yes.
I would say part of the process.
Let's go to page 10, please, in relation to this theme as to metrics and monitoring. And we see at paragraph 8, for some policies, this being October 2020, as we're about in the tier system, departments have yet to establish effective metrics and monitoring arrangements. While this is understandable with more recent initiatives, this must be a priority for departments over the coming months. This will enable the Race Disparity Unit to monitor and assess short and longer term impacts and to assess which interventions are most effective. So the work you had done had revealed that there was an absence in certain quarters of effective metrics and monitoring. Is that correct?
Yes, but this was part of what we were looking to identify, where there were gaps, where some departments weren't doing as well as they could or should. We wanted to highlight that, and I imagine the way we write these documents might seem odd, but there is a lot of reading between the lines. We don't want to demoralize or over criticize the people that we're working with, but it's effectively what this paragraph is saying is that some people haven't yet done what they should be doing. And in the context of everything that was going on at the time, many departments overwhelmed, lots of officials being pulled from their day-to-day work to support in the pandemic, I don't think it was surprising, which is why we said, well, this is understandable. But there was more that we wanted to see, and we knew that people weren't moving as quickly as we would have liked.
Just that last part of your sentence, we knew that people weren't moving as quickly as we would have liked. Just keeping that in mind for the moment, because the question was going to be this. Bear in mind the concerns regarding certain groups being disproportionately impacted. May 2020, it raised, and a report ordered by the Department of Health and Social Care, PHE reporting back in June 2020, were in October 2020 in the grip of a moving second wave, and your concern here that people weren't moving as quickly as we would have liked.
Yes, there would have been more detail. I can't recall off the top of my head, but there would have been more detail in the report about what specifically. There would have been specifics. So this, I can't remember. I'd need to read the report again to remember exactly. But we commissioned this in June. I think it took about a month just to get everything together, get the right people into the RDU to carry out the work, put the terms of reference. So the first report comes out in October. This is after there's been a lull. If you remember, we had a summer where there was a lull in terms of infections and there was some easing generally. So this was just the assessment that was being made in terms of if there's a new spike, have we got everybody ready, I think perhaps to do risk assessments and so on. And departments need to answer them for themselves specifically why that was the case. But we had looked at what they were doing and we felt that by the metrics we were measuring, not everything was being met.
No. Was there, in your view, sufficient capacity to deal with these matters during summer 2020 so that we were prepared for the second wave?
I don't think so. I think that it's a pandemic like that and the amount that we were doing, I'm not sure there would ever have been enough capacity. Because on the one hand, government is doing everything it can to support those who are dealing with the disease. But even we, whether it's the officials, the civil servants, we're also being impacted ourselves. Within the cohort of people working in civil service or people who are shielding or who have family members who are dying and so on. So I don't think that this was a case of people slacking off or people not doing as much as they could do. Sometimes it would be people just not having in themselves their own personal capacity, literally no other person to join, or perhaps those with the right skill set. And you can't skill up quickly for a pandemic, and you can't have pandemic-sized response capacity just sitting there waiting all the time.
Well, I won't repeat the chronology points again, but the last point on metrics is that one of the recommendations, we don't need to look at it, recommendation 10, was that you were going to work with other departmental colleagues to establish metrics going forward. We're going to move on to one last point, which is recommendation 3. So if we could go back, please, to page 5 or page 6, it's probably on. So you have it in front of you. And overleaf, thank you. There should be a rapid, light touch review of action taken by local authorities and directors of public health to support people from ethnic minority backgrounds in order to understand what works at a local level. And if we fast forward to page 9, please, just to help you, because I'm conscious these are long documents which you have seen recently, but some of them are more in the past. Page 9, please. Thank you. The last paragraph. and this relates to this point, is that there's a significant amount of work being carried out at the local authority level and by directors of public health, which is not currently being captured centrally. Capturing this will be a focus in the coming months. So again, drawing that together, your work revealed that there was a lack of visibility in central government about what local government colleagues were doing in relation to these areas.
I'm not sure whether that was about the central government visibility. I think it might have been the RDU's visibility into being a separate department into what was going on. I suspect that DHSC would have known what directors of local directors of public health were doing, and probably in MHCLG as it was at the time, there would have been some insight. But making sure that we had that information and we were able to capture that in our work, I suspect is part of what we were looking at. I can't remember exactly, but reading that now, I think that is what we were saying. I don't think what we were saying was that nobody knows what anyone is doing.
We'll read in context, but you don't like duplicating other people's work. But one of your recommendations is we need to do a review, we need to know more.
Yes.
Dealing with the last themes very briefly, but they're important points. Data remains an issue.
Sorry to interrupt. If I was to refer to, that's point 5, if I was to refer to point 3 on that page, we document what we did, asking for a set of returns, and it could also have been that departments sent us some, but not all of what they had, and making sure that we're reviewing what information they had as opposed to what they were sending was also part of it. Sometimes they just didn't send us everything. They might have thought it wasn't relevant. Sometimes a particular team may not even know what another department, what another part of the department has. But government is very big, and the bigger it is, the harder it is to find information.
Goes back to the question before lunch about your role as Minister of Equalities and whether that had a sufficient seniority and importance to get a response from other departments. Was that an issue?
I think that was not an issue because this was a report commissioned by the Prime Minister, so it had his authority behind it. And remember, I was not the only Equalities Minister. There was a more senior Equalities Minister as well. I never felt that they did not take this work seriously, but I did feel that they were very much at capacity.
Okay. Data, and I'm going to summarise. Data was a real issue. There was no single data set which held all the, quote, variables needed to gain a full understanding. And different organisations have been linking data sets over the last 4 months. We don't need to turn to it as page 14. And it says later on page 20, the emerging picture points to areas of general concern about data quality. So a real feature was we don't have one data set. We're merging a number of data sets. Secondly is that there's issues regarding data quality, data collection, and the need for harmonisation of data standards.
Absolutely.
And that's a feature of the work through the quarterly reports thereafter. Is that right?
Yes, I remember that.
Communications, we discussed it already. It was in your terms of reference. Another one of your recommendations for this first quarterly report was to continue to improve public communications. It was an ongoing issue. Is that fair?
Yes. And
risk, perhaps we could turn to look at this. Page 16, please, second paragraph. Thank you. Risk factors and how some occupations carry a higher risk of getting infected. We touched upon this when looking at the COVID-0 report. As the job cannot be undertaken at home, people still need to commute to work in order to provide essential services for community. And these figures significant. 1.4 million key workers were from ethnic minorities, making up to 14% of all key workers, brackets 5% of total workforce, and 20% of those in high-risk occupations compared to 11% involvement in the total workforce. So there's a recognition there of risk being a factor, and risk being a factor linked to the occupations where certain ethnic groups were more prevalent in. Is that correct?
Yes.
We touched upon already that the 13 recommendations in this first quarterly report in October 2020 were accepted in full by the Prime Minister, and that this formed a framework going forward for your work, is how you said in your statement. I want to fast forward now to the second quarterly report,
Right.
which is in February 2021. So we are now in the third lockdown in terms of the narrative. And if we could open up, please, INQ 000. We have it there. Thank you so much. This was published on the 26th of February. And as you summarise in your statement, it looked at causes of higher infection and mortality rates for ethnic minority groups in greater detail and the work undertaken to mitigate risks. And you explained that the impact on ethnic groups had changed between the first and second waves. Did you want to, rather than be summarising everything, did you want to explain your assessment at that stage? That was quite a significant part of your work.
Yes. I don't have the exact page in front of me, but I do recall that there had been a change between what we saw for black males and, or certainly the black cohort and whites. There was an equalisation in terms of risk. Whereas on the side of Pakistani and Bangladeshi groups, I can't remember whether it stayed the same or it had got worse, but suddenly black African and white British men, there was no disparity, but it continued within the Asian groups.
Yes, that's a fair summary. We have it in front of us there. Perhaps, in fact, if we pull out for a moment, I think page 6, paragraph 3 is probably a better reference. Be wrong. Okay. Let's go with this reference. It says overall the direct impacts of COVID-19 improved for ethnic minorities as a whole during the early second wave, and it describes the difference in the first wave and how in the early part of the second wave the risk of death was the same for black African and white British men. What you just said to us.
Yeah.
And to underline the second part, at the same time, however, the second wave has had a much greater impact on some South Asian groups. Work is underway to consider why the second wave to date has had such a disproportionate impact on Pakistani and Bangladeshi groups. Relevant considerations include regional patterns in the first and second waves, household occupancy and multi-generational households, deprivation and occupational exposure. It says later on in the report that, at page 23, that the continued higher rate of mortality in people from Bangladeshi and Pakistani backgrounds was alarming and required focused public health campaigns and policy response. Can you help us in relation to that? So we see an increase in mortality in relation to the British Pakistani, British Bangladeshi groups. What was done to require focused public health campaigns?
If we go back to what the information was telling us up until really that second quarterly report, the why of why people were disproportionately impacted was not clear. And if you look at the PHE report, especially the stakeholder analysis, much of the belief was that this was due to prejudice, discrimination, racism. What we were finding there was that something different is going on, because we're seeing improvements in some groups and worsening in other groups. So a lot of focus was around compliance with social distancing, whether people understood a lot of the advice that government was giving. And at that point, we were spotting the correlation, which we think was quite a huge causation, about multi-generational families. The big difference between those two racial groups, which were previously roughly equally impacted, was how many of them had grandparents effectively living with the family and exposure to young children. So we put out lots of communication around to diaspora communities. By this point, the Community Champions program is starting, where we know that clearly with some of these groups, not all of them are going to be going to gov.uk to read through all the long bits of advice.
Just pausing there.
Yes.
We've got a remote stenographer, so I'm just...
Oh, sorry.
No, it's not at all. Just to give a pause to your answer.
Yes.
You were dealing with communication
Yes.
and community champions, which is one of the topics I was going to deal with.
Okay.
Explain to those who are listening what community champions were and how that was brought about. Briefly.
Right. So if I take a step back and provide some more context, At this point, we can see that there are multi-generational households who are particularly impacted. We can see certain areas in the country having a higher rate of incidence, and we decide to target the problem and be as focused as possible. And given the terms of reference that I had, a lot of that was to do with communications. And the Community Champions program was one which identified that even with the best will in the world, government can't get everywhere. There are some places that you need other people to do the communicating. So the Community Champions program was to find people who were trusted in their communities who could help seed information around looking after yourself and in particular your family.
So in relation to that,
yes.
So the Community Champions was something which was an important part of your work. Mm-hmm. You mentioned in the reports that funding was granted in January 21, so just at the beginning of the third lockdown.
Yes.
This is your report in February 21. Community Champions and that trusted voice for different communities, was that something which perhaps should have been done at an earlier stage?
I don't see how we would have done that. If you remember, the Equality Hub doesn't have delivery levers. It's almost effectively a research and policy recommendation unit. So Community Champions was delivered by the communities department. Finding out which communities are impacted, this is by the second report, looking for who the right community champions will be. They're not just waiting, it's not a set of people waiting. Getting people to do the work, making sure that the data on where to go, where the incidence is, looking at places where there's high morbidity data, high incidence of death, low levels of English speaking, all of that needs to be captured as well. So you can't just press go and start a project. The departmental coordination needs to be there. Treasury funding needs to go through the right process. Treasury needs to look at the proposal. You can't
just to pause there,
yes.
Because I'm just going to follow up, if that's all right.
Okay.
I understand the mechanics that
yes.
these things, you use your phrase, press and go. What would you say to the challenge to that, which would be we're a country rich in diversity, and there always would be a need to have different communication channels, the way to reach different parts of and different communities. That should be something which is in place already.
I think it is something that should always be considered, but I don't think that even government can create a system that would be in place already to deal with that. If I give you an example, and this is where my own personal experience was feeding into this, and I know this was something that was very common. I'm in a family WhatsApp group with family members across the world, from Africa to the US, all of us experiencing the pandemic, different bits of information being shared, clips of people saying, this isn't real, it's a government, this is a government agenda, lots of conspiracy theory, having to rebut very well-educated people who are bringing in arguments that they're seeing on the internet. The government can't get into my family WhatsApp group. It's just there are some channels which you cannot break into in the information age that we live in. What we can do is try and make sure that as many people as possible have access to the right amount of information, and hopefully that eventually transmits. But there are some things that you cannot rebut. Community Champions was a way of reaching those people perhaps who might not be be digitally excluded, might have low levels of English, hopefully are slightly distant from a lot of the conspiracy theory spread and misinformation spread, but who would perhaps go to a church or a mosque or a religious institution, perhaps a clinic, people who are coming face to face with those who might be suspicious of intervention from governments. And remember, within ethnic minority populations, there is a very high level of first-generation immigrants who come from countries where people don't trust the government. And there is no reason to assume that just because the government is saying something, that they will take it as verifiable information that they have to act on, especially with the backdrop of conspiracy theory.
Well, the lack of trust and the need for trust is something you've mentioned a number of times.
Yes.
And it's a feature of your work, how this community engagement, Community Champions was one vehicle to address that. I'm going to move on, if I may. In terms of areas in which positive measures were implemented as a result of the second quarterly report. We mentioned community champions, community testing, which was taking place, piloted at places of worship in ethnically diverse areas, and tried to enable more identification of higher numbers of cases. I want to turn to page 11, if I may, of this report, which I've highlighted the progress which has been made and the efforts which are being implemented. And we see at paragraph 7, thank you again for the references which are correct. It says this: whilst good progress has been made to address COVID-19 disparities, government departments must redouble their efforts, taking into account the latest available data and evidence. In particular, departments must consider measures that will benefit those most affected by the second wave of the virus, and particularly those from the Bangladeshi and Pakistani ethnic groups. So again, this report recognises and identifies that more needs to be done. Is that right?
Yes.
We talked about metrics, and one of those, if you fast forward to page 49, was your recommendation 10 from the first report. And it was an update in relation to recommendation 10, where you were to write to colleagues, which you wrote to colleagues in December 2020, encouraging departments to establish metrics for assessing the impact of their policies, accompanied by a technical annex. And you also met the Minister for COVID-19 vaccinations. There isn't anything exciting, I don't believe, over leaf. Yes, as I recollected, nothing really more to add in relation to that. Where were we with metrics? You sent information out. Were metrics established to gauge what different departments were doing to address these issues?
I believe they were, although I can't recall exactly what they would have been, certainly not off the top of my head. By this point, the metrics, a lot of intra-departmental metrics were not necessarily things that we would have been looking at. It was making sure that they were monitoring and checking that what they were doing would have been effective. And a lot of what we were focused on by this point was what is the data telling us about who is impacted, what can we do in order to make sure that they're protecting themselves. I seem to recall by this point we were heading into periods where religious festivals were taking place. We knew that large gatherings of people were occurring, especially in certain minority communities, how to make sure that people protected themselves and did not end up in a situation where large non-compliance activities were taking place. But in terms of metrics, not off the top of my head, no. I'm sure they are there, but I can't recall at the moment.
Let's hope that confidence is borne out. But in relation to the time period where we are in lockdown 3. It's February 2021. And next steps, I can outline them rather than invite you to turn to it, was more recommendations on data and evidence, more recommendations on engagement, more recommendations on tailored communications. Let's move to the third quarterly report. It's the 25th of May 2021. We're into summer 21. Things are improving relatively. INQ quadruple zero is right in front of us. Thank you so much. Page 3, please. And we see there in the last paragraph, this report summarises work across government and through national and local partnerships to improve vaccine uptake amongst ethnic minorities, describes a data-informed approach, targeted communications and engagement, and flexible deployment models are the cornerstones of vaccine equality delivery, refers to supporting it during Ramadan, extending the use of places of worship, and at a completeness at the bottom of the paragraph refers to further funding, 4.2 million to local sustainability and transformation partnerships to enable targeted engagement in areas with health inequalities and with communities. By this stage, your work, is this a fair summary, in May 2021, the huge focus of it was in enabling vaccine uptake.
Yes.
Why was that?
Because many of the non-pharmaceutical interventions. I think that's what NPI still stands
Yes,
for.
it does.
Yes, many of the NPIs were things that we were trying to do to help prevent, but in terms of efficacy, we couldn't control a lot of them. You can't control how people behave. In some cases, it's impossible for them to shield, depending on their living circumstances. Vaccines, on the other hand, were proven. And looking at some of the things that I felt would have been contributing to ethnic minority disproportionate impact, not participating in clinical trials would mean that what if people were getting the vaccine and then it wasn't working because of genetics or something else? So increasing vaccine uptake, but also encouraging people to understand what vaccines are about, that they're safe. Taking part in clinical trials was really important to me. I took part in clinical trials myself. I went on the Novavax vaccine trial, publicized that to let people know that this wasn't something that they should be afraid of. There was a lot of fear by this point. The government wants to, how can I put this? There was a fear that a lot of the communication about disproportionate impact was actually a secret conspiracy to scare ethnic minorities into taking vaccines, which was a way of the government culling the population. So even the things which we are doing in order to identify risk were being manipulated into conspiracy theories to deter people from doing what would help them mitigate that risk. And that was something that I was particularly concerned about.
You recognise that there was mistrust in the communities, not one community, and there was efforts which are set out in this report to address that and improve communication and improve vaccine uptake. What do you say to the question regarding whether the balance was right? Was too much of the efforts at this stage into addressing ethnic minority disproportionate impacts on vaccines, should more have been also done in relation to other areas, such as financial support for
I disagree. And I think that we would need to be very careful at this point about stigmatization, which is something that I had very much at the back of my mind. Vaccines worked. This was a fact. This was proven. And to spend time away from what we knew worked to do things which were less viable, less effective, in order to deal with the emotional feelings of people who either didn't like vaccines or wanted other levels of support, I think would have been wrong. But I also think that I remember reading lots of recommendations and lots of reports at the time. What people were suggesting was racial segregation. Let's treat black people differently because they're disproportionately impacted. Let's give them the vaccine first, something that we didn't do, for example, or let's target support packages for ethnic minority communities. And I think that a lot of this goes back to the point I was making about the use of the word BAME, that ethnic minorities don't just exist as communities of segregated people. We are part and parcel of this country. We are related to people who don't come from our ethnic background. My husband is white, my children are mixed race. There are families like ours all across the country. Targeting ethnic minorities in this way, rather than targeting households and families, would have been completely the wrong thing to do. And that applies to both the clinical interventions as well as things like economic packages and so on.
Let's pause there for a second, because it's just, we're on points.
Yes, okay.
And you were talking about support packages for ethnic minority groups. One of the features from your work is that a recognition of the higher rate of mortality in relation to British Pakistani, British Bangladeshi, and in that type of occupations where there is where they work more in. And we talked about key workers as well. So against that background, was it not the case that earlier in the pandemic, perhaps before vaccines, that there should have been greater financial support to help people in areas such in the north of England?
I would say no, and I say this at the time I was a Treasury Minister as well as an Equalities Minister, so it was quite a useful intersection, and I would say one of the advantages of having Equalities Ministers sit in other departments. That What the evidence has shown is that being an ethnic minority was not the cause of being disproportionately impacted. It correlated with what the causes were, the comorbidities. So you have to tackle the actual cause, not the thing that comes in common with it. If you provided support packages to particular minority groups, you would have left quite a lot of people out who desperately needed similar support, rather than targeting the people who were most affected. So, for instance, you could argue that let's give extra money to all Pakistani men. They're disproportionately impacted. I think that would have been a terrible waste of money. There would have been a lot of.
I don't think that was a suggestion.
But I'm giving examples. No, I'm not saying that's what you're suggesting. You could have said, let's give money to the taxi drivers who are particularly exposed, who are from that background, but they are no more exposed than taxi drivers of another background. You could say, well, let's give extra money to all taxi drivers, but then there are other groups of people, not least of all health workers, who are also similarly exposed. There is no perfect way of finding a particular group to give extra cash to, and extra cash in and of itself would not have solved the problem which we were trying to resolve, of making sure people were protected and away from the virus. And if I may, there's one extra point, that what this highlights is the trade-off that we as government ministers have to balance. The deprivation is one of the reasons why people say that there's inequality. Making sure that people can stay economically active. It's not just about the earning of the money, but also the things that come with it. If you reduce that, you also create factors that can lead to inequalities later. So we have to look at all of those things in the round and find the right balance.
Well, can I ask you a question in relation to this? Because I'm conscious that there's a long answer and I don't want to lose us all.
Right.
So one of the areas which is an alternative was whether there should have been more financial support in relation to those occupations, or people generally, putting an ethnicity to one side, who may have been self-employed or working in low-paid areas, which, if they were sick, that they would get sufficient financial support so they could self-isolate. That's the vehicle for this sort of support, which has been, which I'm sure you're familiar with. Was that not something which your work should have included, or at least explored?
That was work that was taking place in the Treasury. I wasn't the minister responsible for that, but that was looked at in the Treasury. I'm afraid I only have the Equality Hub notes for this module, but that definitely was done. And I remember standing at the dispatch box and explaining how we came to devise the packages which we did. There always has to be a cut-off, and there is a cost to everything. So the package, the furlough and a lot of the quantitative easing and money printing, which we did then, is directly related to some of the issues that we're seeing now with high interest rates, with inflation. So more interventions are not without costs or consequences. And there needs to be, at some point, a line was drawn. Yes. Even where we drew the line, people asked that it should have been for people earning slightly more. They felt that the £50,000 cutoff, which we had, was too low. There's always, no matter where you draw the boundary, there will always be people who feel that they're on the wrong side of the boundary and should be included. And if you take that to its logical conclusion, we should do it for everybody.
Well, let's draw a metaphorical line under this for the moment. We're still on your third report, and I want to move on to page 5, if I may, which is a third line, and just draw out what we're discussing. We're discussing British Pakistani, British Bangladeshi, and what the data was showing here. And by this stage, I think it's the third line. This third report summarises the data for deaths in the second wave up to 31st of January, which was not available. The latest data confirms the findings from the second report that people from South Asian ethnic groups, particularly Pakistani and Bangladeshi groups, were at the greatest risk of death from COVID during the second wave. And in terms of those numbers, I'll summarise it at page 22, is that compared to white British men and women, Bangladeshi men and women were 6.1 and 6.3 times more likely to die from COVID. Pakistani men and women were 4.4 and 3.8 times as likely to die from COVID. And they reduce, but not significantly, for other factors as well. In relation to one other feature which arises in this report for the first time, and it's an interest to groups which are core participants, is at page 29, and long COVID. That's something which is raised for the first time in this third report. And I'm just going to touch upon it briefly, if I may, and ask you what work, if any, was done. It describes long COVID as an emerging phenomena that is not yet fully understood, and describes the impact of that, which I can summarise. But the prevalence rates were, for self-reported long COVID, were highest for people with a pre-existing activity, limiting health condition, and B, health and social care workers. And we see that in the middle of the page. And in very simple terms, those in the white ethnic group had the highest prevalence rates of long COVID compared to the Asian ethnic groups. Quick question on an important topic, but in relation to your work, was there, this is the third report, was there any work done to explore long COVID in terms of its impact on ethnic minority groups?
No, I think for several reasons. One, it would have been outside our immediate terms of reference. This is very much health work, and by that I would say sort of frontline research analysis, whereas the analysis that's done within my unit is more statistical. But it was something that we thought was worth highlighting, especially, certainly my personal opinion, the health and social care workers was emphasising that there's something to do with exposure. Being exposed is likely to, or the frequency of exposure is likely to trigger long COVID. But we would not have been the right place for that kind of work to have taken place. But it was something that we thought was worth referencing in this report.
Thank you. We fast forward to the final report, which is the fourth quarterly report, which is dated the 3rd of December 2021. So just as we are, Omicron is around at that time, December 21, and this was a long report, even for the reports you undertook on our behalf, 133 pages, and we see, if we could turn to page 5, please. The understanding is much clearer in your view and the work that was undertaken on your behalf. The main factors behind the higher risk of COVID-19 infection for ethnic minority groups included occupation, particularly for those in frontline roles such as NSH workers, living with children in multi-generational households, and living in densely populated urban areas with poor air quality and higher levels of deprivation. So occupation, deprivation, and household make up significant factors. Once a person is infected, factors such as older age, male, sex, having a disability, and we touched a lot on disability, or a pre-existing health condition such as diabetes, and you've touched upon that, are likely to increase the risk of dying from COVID-19. And in relation to the work you've done, your summary was in a statement that vaccination was the most significant measure in your view to protect ethnic minorities. Was that the position?
So
Shall I say it again?
Vaccination was taken in a sufficient enough.
No, I'll say it again. It's my fault if it's lost. What you say in your statement is that vaccination was the most significant measure to protect ethnic minorities. And you point, if we perhaps could turn to page 6, please, is that the conclusions in this report really form your recommendations going forward.
Yes.
And you describe how there is a number of wider public health lessons to be learned in relation to ethnic minorities, including talking about vaccination deployment in other public health programs. In other words, the lessons we've learned in relation to COVID vaccinations can be used for other work. And reference to using community champions or respected local voices to build trust and tackle misinformation. A point you've made, and we recognise at the outset, not to treat ethnic minority groups as a homogenous group. And there is not a one-size-fits-all approach.
Yeah.
Not controversial. No.
I hope not.
No, not that aspect, recognising that there is more than one community. In relation to, thank you for turning over, Leaf. avoiding stigmatising ethnic minority groups by singling them out for special treatment. We've mentioned it a couple of times. Perhaps this is the opportunity to deal with that and stigmatisation. What was the concerns regarding stigmatisation during your work in relation to the impact on ethnic minority groups?
So one of my duties as the guardian of the Equality Act is looking at social cohesion, and it is important that we don't let the good intentions take us down a path that's actually counterproductive to what we're trying to do. And quite often, very well-meaning people think we need to do this for this group so that they can see that we care. But that often has other unintended consequences. And one of them, I remember, was for a certain period, there was a large belief or there's a significant number of people believing that it was ethnic minorities who were spreading the virus because they were talked about so much. They're the ones catching it, and if they're disproportionately impacting it, they must be disproportionately spreading it as well. Anything that looks like certain groups are being treated better than others does not work because it goes against the principle of equality before the law and everyone being treated regardless of their ethnicity. And the Equality Act states very explicitly that positive discrimination is illegal. And many people don't understand that lots of these ideas, well-intentioned as they are positive discrimination, and they don't help in the long run. And certainly, given the way that we were lumping together lots of groups, they didn't help in the short run as well. When you mixed all the different ethnicities, you lost the insight about multi-generational households, and you ended up spending time looking at problems like who was being racist or if there was a racist that was causing those problems. We would not have fixed the problem by focusing on the wrong issues. So stigmatizing is something that I am very concerned about. I believe that it is my job to make sure that people treat ethnic minorities in a colorblind way. You look at the individual, you look at their circumstances, not start off with their skin color and start to make deductions based on that.
And a final point here is in relation to a feature which is about data, improving the quality of health ethnicity data so that patterns and trends can be spotted quicker in the future.
Yes, and one of the recommendations, I think that would have come in an earlier report, was even about recording ethnicity on death certificates, which was something that we discovered was not being done and was a big issue. So,
just in relation to that, because that's one matter which I would like your assistance on. Because, because this was something which was around, just to help you in timings, it was one of your recommendations in the first quarterly report.
Yes, I think so. First or second? Yes.
I believe it was the first, okay. But we can, if we're wrong, it's my fault. But it's a first quarterly report. Why was that something which you were of the view needed to be recognised and ethnicity would be noted on death certificates? Because
I felt that if we had had that, and I don't know why it wasn't recorded, I don't know if there was ever a reason, it was just something that wasn't recorded. If we had had that, we might, not certainly, but we might have been able to spot the disproportionate impact a little bit earlier. But this was certainly speculation, reasonable speculation on that basis for that problem. But it seemed an odd place to not capture it, given that we capture it in all sorts of data sets.
Two final questions. First one, your view of the greatest success of the work that your team achieved in relation to this area.
Yes, I think we had a lot of successes. Actually, I'm very proud of the work that my team did. I think under a lot of pressure and with very high expectations, I think that they delivered. I think the work that they did was rigorous. It was very carefully done. It was very sensitive. They won an award. In fact, they won an ONS award in research excellence for the analysis that they did, and that was in competition. The other shortlisted people were universities. So the quality of the work they produced was very high. And it was it was a very painful process because I went through all of these reports line by line, making sure that they were written in a way that people would understand. We quite often get a lot of documents in what I call officialese, where the information is obscured. And I hope that that's been helpful, actually, to the inquiry, the way that the documents were presented. I think we saw things like greater vaccine uptake because of the work that we did and some of the recommendations we made, family jabbing, for example, so that people felt more comfortable doing this because they had people taking the vaccine because they had people who they cared about and who they trusted going along with them. Things like increased participation in clinical trials by ethnic minorities, which I think is important if you're going to get vaccines that work and pick up the right data on health issues. So I think there are a lot of successes.
Thank you. So, and the other side of the coin, with the view to learning lessons, what do you think is the greatest lesson we can learn to improve going forward in relation to this area?
Where does one start? I think, for me, I am still very, very concerned about the issue of misinformation and just how, even, and I say this even as a constituency MP, the number of people who come up to me in the street and tell me that I am part of a grand conspiracy to infect them and so died because of the material that we were putting out is very disturbing. I don't think government's got a handle on dealing with misinformation. I don't think that we have adapted to this age of social media carrying, where information travels at lightning speed across the world. I don't know how we solve it, but in terms of gaps, I think that there was a lesson in the pandemic that that this is an area that needs more addressing. And I hear of a lot of work being done in departments, whether it's Cabinet Office or DSET, I'm not sure, but I don't see it. So maybe there is lots of work being done and it's covert, but it's hard, if that is the case, to know what is being done. So I think that's an area. I think another area that we should have done more on was on the economic impact. We were looking very much at the health side, and I think that we should have had an economic impact of lockdown. I think that now we are seeing many outcomes which are related to the missing children in schools, for example. What happened to them? No one's quite got to the bottom of that. The economic impact of lockdown, how that might have triggered even more inequality further down, even if people had furlough or a safety net immediately. I'm not sure that work was done because we were very, very focused on the health side. And I think when we have these sort of grand problems, we need to have multiple lenses through which we're looking at them. And this is hindsight analysis, but the fact that we looked at things purely from a health perspective without without opportunity costs analysis or what was happening, looking at it through another lens, I think we should not have done.
And you were a junior Treasury Minister during that time as well, and that's an observation you recognise. I said it was my last question. I will keep my promise. My lady, there are the questions all I have. You've granted permission to core participants, but it may be that lady wants to have a short break before we move on to that.
No, I'm going to carry on. If the stenographer has to take a break, then she'll take a break.
I understand. Thank you.
So if Mr. Thomas is ready, I am. Thank you.
Ms. Badenoch.
Badenoch.
Let me introduce myself. I'm Leslie Thomas, and I act on behalf of FEMHO, the Federation of Ethnic Minority Healthcare Organisations. I have a small handful of questions, but can I just pick up on something you said to Counsel to the Inquest just a moment ago? You were talking about tackling the cause as opposed to just looking at the issue, why certain groups were affected disproportionately. One of the reasons for that surely would be structural inequalities. Would you agree?
I'm not sure that I do agree, because it depends on what you mean by structural inequalities.
Poverty,
yes.
for example.
Yes, but we don't have a cure for poverty. If we did, we would have done it.
I haven't
already.
finished.
Okay.
Poverty, for example, discrimination based on race, perhaps gender, perhaps other factors such as, we know that some people suffer from disability, suffer from discrimination. So factors such as that, that's what I mean by structural inequalities.
Okay. So you mentioned discrimination as an example. That was not something that was found in any of the evidence that we carried out. And these are things which there are processes in place to address. But in terms of the issues around deprivation, poverty, health comorbidities, a lot of work was done to look at things that we could do to tackle that. But we can't cure diabetes. We can't remove poverty. So saying that structural inequalities had an impact on incidence, yes, that is true, but that doesn't mean that there is a silver bullet to resolve them.
Do you remember in your evidence this morning, I think we can agree on this, you said that the label BAME is unhelpful because it's kind of like a one-size-fits-all, and you need to look at the situation and the impact, and it's much more nuanced. We can agree on that, yes? That BAME is an unhelpful term.
That is what I said.
Yeah. So with that in mind, and I'm not going to call up the documents unless you want to go to them, but I'm referring to your witness statement. And just for the record, paragraphs 44, 47, 48, where you discuss disparities and they're highlighted. My question is this: how were the intersection of ethnicity with other factors such as gender, disability, socioeconomic status dealt with?
So if by intersectionality you're talking about a coincidence of protected characteristics, that would have been taken into account just by looking at the cohort of people who were being sampled. So, for example, when we looked at the intersectionality of age and gender, we found that being male was a bigger issue than being female in terms of catching the disease and, in fact, dying from it. We looked at the intersectionality of things like age and disability. So that was all taken into account. We may not have called it intersectionality, but there were lots of multivariate analyses that took place, including things like geography, which don't always get taken into account.
Let me cut to the chase. If you took into account the intersections between certain factors, and you've outlined some of them, did you in government have targeted strategies to address those disparities comprehensively? And if not, why not?
The strategies we had would have dealt with intersectionality in and of themselves. There is no reason to believe that there was there was a gap. There is no, unless you can give me an example of a gap that you have identified, I'd be quite keen to hear it.
I'm going to ask you this. Do you accept that gathering and understanding the data was important?
Yes.
Right. So we can agree on that. Can we also agree that because of the importance of data, particularly data inherently related to disparities, efforts should have been made to make sure that data was accessible and transparent to the public? Can we agree on that?
Yes.
How was this done?
Well, the reports that we published provided our assessment of the data, but we don't hold data. Data is held by public health authorities, by the ONS. Is there specific data that you feel was not published that should have been published?
Given the heightened risks faced by certain groups, and you've mentioned in particular men of Pakistani origin, and because I represent healthcare workers, I'm just interested to know that some of these disparities were highlighted very early on. We know that, for example, the first 10 doctors who died from the virus are doctors of colour. We know that, and we've heard evidence. Can you just help the inquiry with this? If this was known fairly early on, what specific initiatives or measures were taken and implemented to prevent those demographics from that disproportionately high risk of exposure and mortality?
Well, the first thing we did was the report that we commissioned by PHE to check what was going on. That was one of the anecdotal pieces of information that alarmed me. But knowing that the first set of doctors who died were from an ethnic minority background doesn't tell you why they are dying. It just tells you that that is happening. So finding out the why is important to address the issue. And as we've seen from all the research that has been carried out, if we had simply made an assumption that being an ethnic minority in itself was the risk factor, it wasn't. This was not a disease that targeted people on that basis. Then we would have carried out the wrong interventions.
On the 4th of June 2020, following the publication of the Public Health England's review on the COVID-19 disparities, it was put to government by Jill Furness that the report simply confirmed what was already known and failed to make any recommendations. She asked government whether government were listening to the calls for employees to risk assess Black, Asian, minority ethnic workforce, and in response, you said on behalf of government that you needed to wait to ensure that we do not take action that is not warranted by the evidence. We must widely disseminate and discuss the report before deciding what needs to be done. Question. In the light of the substantial and severe disparities in the infection and mortality rates, which was evident from the widely publicised data sets and statistics from late March 2020 onwards, why did the government feel the need to wait before taking any action in response?
I'm sorry, I lost the thread of the question.
Let me break it down.
Thank you. Yes.
All right. So we've got the report in 4th of June 2020, highlighting the disparities. It was put to the government by Jill Furness that the report was...
And when was that on? When it was published, or at what point?
It was published on the 4th of June 2020.
And when did Jill Furness make
Shortly
this
afterwards. I can't give you the exact date, but shortly afterwards, what Jill Furness has put into you and government is, well, the report is simply confirming what's already known. Okay. And the response was, she was suggesting it was important for the government to risk assess, to call on employees to risk assess Black, Asian, minority ethnic workforce. And in response, you said on behalf of government that you need to wait to ensure that we do not take action that is not warranted by the evidence. We must widely disseminate and discuss the report before deciding what needs to be done. My question is, in the light of the substantial and severe disparities in the infection and mortality rates evidenced by the publicised data sets and stats since late March, why the need to wait?
So we didn't wait.
I'm not at all sure that this is an area on which you've given permission in the Rule 10 process.
I was thinking the same, Mr. Thomas. This wasn't a matter that was raised in Parliament, was it? Who's Jill Furness?
Milady, I'm surprised at the intervention because we were given permission to ask this question.
Maybe I've got the wrong copy, Mr. Thomas. It may well be.
Yeah. So I'm looking at the permission, and it clearly says CP may ask this question. However, please reformulate the question.
Oh, I remember saying that.
Yeah.
So the only other concern was it's not to do with proceedings in Parliament, is it?
No.
No. Thank you.
Jill Furness, I believe, is an MP, a Labour MP. Am I correct?
Yeah.
Right. Okay. So, first of all, the point of the report, which she was referring to, was about understanding whether what was suspected was actually the case. So her saying these were things that were already known, they were not known, they were suspected, there were assumptions, there was no data, and so the report had to be done. In terms of the point I was making, it wasn't specifically to risk assessments. The risk assessments, we didn't wait to start the risk assessments. They were already in train, and they went on for an extended period of time, so that was not a problem. What I was referring to was not knowing why something is happening means that you don't know how to fix it. And that means looking at a report and getting the data out. And as it happened, I didn't think that the report that PHE published answered the question why, which is why we carried out our piece of work.
Milady, those are the questions that I've been...
I'm very good, and I'm sorry to have interrupted, Mr. Thomas. You know the concern about we're not allowed to trespass.
I understand. I was just surprised at the intervention, bearing in mind that it was clearly within the document.
She asked me the question in Parliament, I believe. I don't think there would have been any other place that she would have asked it.
Right, anyway, It's done now, Mr. Thomas. Anyway, I apologise for interrupting. If you had permission, by the sounds of it, it probably shouldn't have been given permission. That's my fault. Right, next I think it's Mr. Stanton. Mr. Stanton's over there. Don't worry, all the advocates that sit over there understand they're going to get back to them every so often. Right. So, but can you please make sure that we still record, you still use the microphone? Thank you.
Thank you, my lady. Ms. Badenoch, please don't feel any need to turn to face me if it's slightly awkward. I think it's more important that you're able to speak into the microphone.
All right.
I'd like to briefly revisit an issue that Mr. Keating addressed with you earlier in your evidence in connection with the Public Health England report of the 2nd of June and the concerns that you made reference to of a number of organisations about the possibility that information had been withheld from that report. I'm asking questions on behalf of the British Medical Association, the BMA. And you may be aware that the BMA was one of the organisations that made representations to you. You may recall on maybe not the dates, but it was on the 5th and the 7th of June.
Yes.
On the 12th of June, the matter was escalated to Matt Hancock in the Department of Health. And I'd just like to bring up for you that letter on screen, which is INQ 0000978772. And just to draw your attention to the first paragraph, which states, I'm writing to express our serious concern at reports that 69 pages covering 7 recommendations for change were removed from last week's Public Health England report on equalities and disparities in the impact of Covid-19 on certain groups. A clear response is needed as to why these pages and important recommendations were omitted from publication, especially when it is so critical that action is taken to save lives now and reduce race inequalities. And subsequently, 4 days after this letter, a 69-page report was indeed published with 7 recommendations. And I appreciate what you've had to say about the circumstances of this publication. But was it not the case that the fact that information had been removed from the original planned report had become an open secret, and that forced the government's hand to publish?
Absolutely not. And I'm actually grateful for the opportunity to set the record straight, because this was something that caused an immense amount of frustration. And when I referred to personal abuse in the earlier session, this was what it was about. The health department commissioned a report, but 2 reports were received. It was not 1 report. However, people who were contributing were not aware of that. So they assumed that their contributions had been withheld. What we did was we published the first report immediately, what we'd asked for, and taking away the second one, which had recommendations which were actually not that easy to understand, things like cultural competency, there's no clear definition of what that means, meant that it took some time for us to look at what our response to it would need to be. And that was one of the reasons why, in addition to the first report being what is going on rather than how we fix it, that's one of the reasons why we carried out the second piece of work. But I would like to state on the record that is absolutely not the case that anything was withheld and only published because we were concerned about complaints. The fact of the matter is, this report was not written by government. We could not have suppressed it anyway. PHE could have released it if it wanted to. It could have been leaked. So it would not have been a sensible thing to even have tried to suppress it in the first place. Sometimes things don't happen quickly. It doesn't mean that there is a conspiracy to hide information, and that's the response that I gave to the BMA at the time, and which I would like to put on record.
Thank you.
Thank you.
The 69 pages deal exclusively with the issue of disproportionate impact on ethnic minority groups. And as you'll know, the BMA became very concerned from an early stage, from April 2020, about this issue, particularly as early data had shown that among the doctors who had died in the early months from COVID-19, 94% were from a BAME background. Given the seriousness of this issue and the seriousness of the BMA's concerns, what was it about this particular area that necessitated a separate report?
It was qualitative analysis, not quantitative analysis. And the recommendations, as I said, were actually not very clear, although we did in the end understand after a lot of engagement with PHE and with Professor Kevin Fenton, who was the London regional director. But when you have recommendations like having cultural competency, that could mean any number, of things. Simply publishing that without a clear response or a clear idea of how to carry out those things, I don't think is a responsible thing for a government to do. But also, the BMA was rightly concerned. They are a trade union for doctors. If doctors are dying, they should be concerned. I was concerned. My father, who was alive at the time, was a black doctor. If doctors who were black were impacted, this was something that would impact me. So I did care about this issue. But I think that there is so much suspicion now around the motivation for something being published that aspersions were cast which it didn't need to be. We took this very seriously, and we worked closely with them in order to get those recommendations acted on, and they were.
One of the perhaps areas in which misunderstanding has been allowed to creep in is because the original terms of reference of the review included a requirement to make recommendations.
Yes.
And recommendations only appeared in the second report.
Yes.
Was that part of the problem, do you think?
No. And in fact, I did get an apology from PHE for doing that because they mixed the two things together. They didn't provide, and that for me was actually highlighting the fact that they didn't know what to do on the substance of the findings which they had. They didn't make recommendations as we had commissioned. Instead, they did a separate piece of work that was different and made recommendations there.
Thank you very much for clearing those matters up. I just want to move to a separate topic very quickly. Recommendation 4 of the second report concerned the need to accelerate the development of culturally competent occupational risk assessments. And I'd just like to ask, in the work that you undertook following the report, what progress were you able to make in this regard, particularly having regard to the impact that a risk assessment can have on safety for doctors and healthcare workers?
So one of the things that is a limitation for me as a qualities minister is that I don't have levers. And this was not a report for me. This was a report for the Department of Health. So I would not have dealt with that recommendation. However, I do recall that areas like PPE and how they might have fitted on people of different ethnicities and, in fact, people of different sexes and so on, a lot of work was done in that space. I remember it was discovered at the time that some PPE, which was just uniform, was unsuitable, and this was for lots of different demographics. That's one example. So I do know that work took place, but it wouldn't have been within the remit of my department.
Thank you. Thank you, Madeleine.
Thank you very much, Mr. Stanton. Mr. Friedman.
Thank you, Madam Secretary of State. I act for 4 national disabled people's organisations. We've listened to your evidence carefully today, and you've explained that disability as a matter of generality was not in your remit, and you not wanting to duplicate, but you've said that you were interested in how disabilities, in your words, interact with health outcomes, and you gave the example of diabetes. Yes. My questions are about how government struck the balance between non-duplication and important matters of interaction that, as it may be, needed joined-up thinking.
Right.
Firstly, when Justin Tomlinson gave evidence to the chair, we asked him what he understood the reason at the time was for why disabled people were not included in Minister Badenoch's investigation and the published reports across 2020 and 2021, and his answer was, I don't know. And that's day 20, pages 223 to 224 for the record. So was he consulted on that matter?
I don't remember whether he was consulted on that matter. However, the Minister for Women and Equality, our senior minister, who had overall responsibility for this area, would have known about it. I can't recall. However, if we look again at the genesis of how this report came to be, and it relates to the previous question on intersectionality, which was asked by the previous council, you need to be able to disaggregate data before you can look at them in the multivariate analysis. You can look at the way that they interact. So whether or not we took this work into account, the data within our work stream, or they looked at it separately, the data would still have been there. So if the question...
Well, I'm going to come on to, I'm only interrupting you, so to say, just because I'll come on to that. But I think the answer you've given is you don't know about Justin Tomlinson, but you think maybe Liz Truss in her position?
I don't recall whether or not Justin Tomlinson was, but Liz Truss would have been.
Right. I'm going to ask a second question following that, if I may, which is that we have seen none, but was there a documented decision along those lines around disabled people in relation to your investigation, or is it a more informal consultation that you're recalling?
I don't think it is either. If we look at the one of the quarterly reports where we talk about a separate work stream.
It's the final one,
yes. December
2021 in a footnote.
Yes, where we talk about a separate work stream. This is a directorate that has all these units working together. But the knowledge of disability as having such a severe impact meant that it didn't need to be within my bit of work.
Right.
With if I may,
yes.
With the bit of work that I was doing, my work stream, we're trying to understand why ethnicity would have had an impact. For disability, it's a lot more obvious. There were fewer questions to be asked about why disability is having an impact. It's clear to see. So there was no need to mix those two work streams together. And in fact, I would not, even knowing what I know now, I would not recommend it.
Well, I understand that. How much discussion, though, did you have with Minister Tomlinson, or indeed the disability unit, about how disability or disabilities interact with health, and in your work, how the various ethnic minority groups could also be parts of disabled groups and vice versa when it comes to risk and outcomes?
I would not have needed to have those conversations because that happens anyway. If you are disabled and work is being done around disability, ethnic minorities who are disabled will be captured, and vice versa. So this is we don't need to have a discussion to make sure that this happens. This will simply be the case.
Well, we don't need to study all your published reports, but you don't deal with it in any way at all in your reports.
We don't reference it because we are speaking specifically. The report is about ethnic minorities. So we are talking specifically about that. We didn't. There are 9 protected characteristics. Age is a huge, was the biggest factor. That is also not mentioned in the report. That didn't mean that old people were neglected during the pandemic.
And then lastly, this, you've been asked about intersectionality and perhaps the difference between how much it was considered in substance as opposed to definitional form. But the Oxford English Dictionary defines intersectionality as the interconnected nature of social categorisations such as race, class and gender, we would add disability, regarded as creating overlapping and interdependent systems of discrimination or disadvantage, a theoretical approach based on such a premise. Secretary of State, do you recognise intersectionality as a matter that all inequality-related ministerial portfolios ought to have taken into account during COVID response decision-making?
No, I would disagree with that, in fact.
And in the short time we have, could you say why to the chair?
Because, as I think if we go back to the question around BAME, the sort of work that we do requires quite a lot of disaggregation. The whole purpose of multivariate analysis is that it's looking at different, incidence rates, and it then looks at them in terms of how they interact. So starting off with the intersectionality is not how you should do it. You start off with the disaggregation. You can layer the data together to come out with what intersectionality may be occurring. But if you do it the other way around, you get a mixed picture. So I certainly wouldn't recommend that. And I wouldn't start off by using the term intersectionality as a way to find out exactly what the answer is. What we are doing in government is trying to use our resources as effectively as possible. So we start out with the measures that will help the largest number of people, not the measures that will tackle the most niche groups, whose intersectionality of race, of gender, of sex, of class, and so on. That is very complicated data that actually require an analysis that actually requires a lot of work. If you are dealing with a pandemic and there is a lot going on, you need to be able to manage resources effectively. And starting off with work that is the most complex means that you will help the least number of people. And that is why I would not recommend that.
But I think you've taken my question as a always do it first.
Right.
I think your answer is, I never recommend doing it first for the reasons you've just given. But you don't seem to be excluding its relevance once you have done, as it were, the more disaggregated work.
Yes, but you use the term intersectionality. Epidemiologists would talk about multivariable analysis or multivariate analysis. They are not different things.
Yes, but am I right? Never first, but a formula of that kind relevant to all work within the scheme of things.
I think it's probably safe to say that that is something that is routine. I don't think it's something that is neglected.
Thank you, Madam.
Thank you, Mr. Friedman. I think there was a matter that wasn't covered by Councillor Inquiry's questions, and therefore, Ms. Sayyidas, I think you're going to ask a question. Can you see the questioner?
Can you see me?
Yes, I can.
I'm grateful, my lady. Secretary of State, I appear on behalf of Southall Black Sisters and Solace Women's Aid. I only have one question for you relating to the overall responsibility for victims of domestic abuse in government. Can you see me?
Yes, I can.
Your role as Women and Equalities Minister is not a cabinet position, but looking at the wider needs of victims of domestic abuse during lockdown and their children, including, for example, housing, just one of many examples, affecting domestic abuse victims. Is it correct that these issues are spread across various departments without there being ultimate responsibility in one minister or department?
I don't think that is true. We have a minister for safeguarding who put through domestic abuse legislation, and what you have described would primarily sit with that minister. But there was a minister for women, there are ministers, and there was a minister for women and equalities as well, separate to me as minister for equalities. So actually, I think that this is something which is covered by one minister, but loads of others actually provide support in that space.
I'm grateful, my lady.
Thank you very much indeed. I think that completes the questions.
It is, my lady. Thank you so much.
Secretary of State, thank you very much indeed for your help. And I'm sorry I had to ask you to come back after lunch, but...
No, not a problem. Thank you very much.
Very well. I think that completes the evidence for today. And we shall return, is it the 27th of November? Come back?
Sounds good.
20... Losing track of the days and the months. 27th of November at 10:30. Thank you, everybody.